evening, all respected members and the newly elected office bearers. Our journal journey is of Maharashtra IIP along with Raigad IIP, and it is a purely academic activity. This month is dedicated to neonatology. Once again, I welcome all the respected members and I hand over mic to our Raigad IIP editor, Dr. Neha Singh, for a formal welcome. Over to Dr. Neha.
Thank you, Chitra ma'am. Good evening to all the respected dignitaries, my seniors and colleagues. On behalf of Maha IIP and Raigad IIP, I welcome you all for today's journal journey, that is 1st of November. In absentia, I welcome Maha IIP President Dr. Sanjay Pakmore sir. I welcome Dr. Amol Pawar sir, and Dr. Minash Sheikh sir, Dr. Niman Mohanty sir, Dr. Vikas More sir, and Dr. Mahesh Moite sir. Then I welcome both the experts of today, Dr. Om Prakash Jamadar sir and Dr. Tanmesh Sahu sir. I also welcome both our presenters of today, Dr. Kranti and Dr. Rajat. I welcome all the other members who have joined for today's session. Now I hand over to Dr. Vikas More sir, President Raigad IIP, to welcome all the respected dignitaries. Over to you, sir.
Thank you so much, Neha, for giving the opportunity. First of all, on the behalf of IIP Raigad and Maha IIP, this is a joint academic collaboration which we are doing since many years. And in absentia, Dr. Sanjay Pakmore sir, who is always behind us for all these activities, and in presence of Dr. Amol Pawar, who is always support us in this activity. Today is a very special CME because we are having very good faculty today. First of all, Dr. Krati Jain, who has done a fellowship in neonatology, and she's a board certified lactation consultant. She is currently working at Vadia Hospital, and she will be presenting.
Neha, you can share the PPT. You can share the introductory slides.
Yeah. So she will be deliberating upon the norepinephrine versus dopamine, the use of norepinephrine versus dopamine in neonatal septic shock, a randomized control trial. And importantly, we are having the doctors Om Prakash Jamadar as an expert for this, who is working as a senior neonatologist at Apollo Hospital. We all know that he has done his MR, CPCH and DCH in UK, neonatology fellowship from Royal College of Pediatric and Child Health in London. And he is doing this work since years in Navi Mumbai. And he's a faculty at National Neocon and Ma-Neocon many times. We know him very well from our area. Then we are having Dr. Rajat Nagargoche, who is a senior resident working at MGM Medical College. MGM Medical College, and we will be working, we will be deliberating upon the article on recent advancement and the best practices in newborn feeding. And we are fortunate to have Dr. Tanmesh Sahu as an expert who has done his DM neonatology from Sion Medical College and right now aiding the NSU at Medicover Hospital and also at MGM Medical College. So today, both topics are very interesting and they are useful in our day-to-day pediatric practice. And I also especially noticed the presence of Dr. Mahesh Moite sir, and then senior pediatrician from IIP Raigad, then Dr. Ravindra Sonone from Nasik EB Maha IIP, and many senior colleagues who are here to bless us. I will not miss Dr. Amol Pawar, who will, I request Amol Pawar to share a few thoughts for this year.
Thank you, Vikas More sir. Already you introduced both the experts, Dr. Om Prakash, Dr. Tanmesh, and also both the presenters, Dr. Rajat and Dr. Krati Jain. So this has been a very good activity, and it starts on first day of each month, first day of each year since last 3.5 years, and it is well supported by Dr. Hemant Gangulia, Dr. Our Jay Bhandarkar sir, and all very well coordinated by Dr. Chitra ma'am and Dr. Neha. So journal journey since last 3.5 years, we are continuing with Maharashtra IP once Dr. Hemant Gangulia took over in 2022. So almost it is 4 years now. Almost after 2 months, it will complete 4 years with Maha IP, and it was started by Raigad IP alone 6 months prior to that. So I think next year we can request Dr. Neelam Mohan ma'am to take it as a national activity, and with Mohite sir in the OB now, so he can pursue Dr. Neelam Mohan ma'am to take it as a national activity, and we can have experts and we can have presenters from all over India. 1.5 year back, we tried for other to take this activity in other zones also, and presenters and experts were there from other zones, in the tenure of Dr. Ram Gopal Chezara. So Mohanty sir has been always the backbone, and I again congratulate Dr. Mahesh Mohite sir, Dr. Ravindra Sonani sir, newly elected executive board member, and Mohite sir as a joint secretary admin. And I also welcome Dr. Mina Sheikh sir and all the delegates and office bearers who have joined from all over Maharashtra, and all the PG students as well. So best of luck to both the presenters, and thank you both the experts for taking efforts in making this making this presentation for this both the presenters good one, and we'll see how it goes. And Dr. Mohanty sir, Dr. Mahesh Mohanty sir will be there to guide along with Dr. Meena Sheikh sir. So thank you, and over to you, Dr. Neha or Chitra ma'am.
Thank you, Amol sir. Now I request Ravindra Sonavne sir to share his opinion.
Madam,
I think so, sir is driving. We can request Dr.
No, no.
Meenakshi sir.
Ravi sir, please mute your video. Please stop your video. Ravi sir, please stop your video. Now you can speak. Neha, otherwise please move ahead.
Sir, I request Dr. Meenakshi sir to give his opinion, and he has always helped us in our journal journey the whole year. Over to you, sir.
thank you, Neha. Thank you, Team Raigad IP. Thank you, Mahesh Mohite sir, Mohanty sir, and all. And I'm really delighted today because Dr. Krati Jain is our own student from Lilavati Hospital, Mumbai. And she has trained at Lilavati and trained at now Wadia and working neurologist as Wadia. So I'm really happy and delighted for each and everyone being the part of this. Over to you back, Neha.
Thank you so much, sir, for your blessings. Now I request Dr. Mahesh Mohite sir to give his blessing. Over to you, sir.
I think, Neha, we are at 9/11.
Yes, sir.
This is a very, very bad number. 9/11 we remember for different reasons. But I think, first of all, thank you very much for this session being continued. We have almost finished 5 years of this session, something really extraordinary in the whole history of IIP at even national level. Some kind of a journal activity going on for 5 years relentlessly. Whatever number, I think the most academically interested people are joining this without any kind of other interest. So thank you, the Maharashtra office body, the president, the secretary. Amol has always been there. Pakmode sir has been always a support. Yes, presidents have done such a wonderful job. And I'm really joining. I joined this today for my area of interest. It's intensive care today. I love this part. And I'm sure there's going to be a good kind of a discussion today. I think Ramakant is also joined. Yeah, Ramakant Patil, who is also a present ED, today's elected ED. So thank you all for continuing. Please continue. And as Amol said just now, I'll definitely talk to Dr. Neelam Mohan She is a wonderful academician and she will take this up at a national level. We'll try and do that at the national level. Thank you very much. Thank you.
Thank you so much, Maheshmati sir. Now I request our first presenter, Dr. Kranti Jain, to start her presentation and switch on her camera.
Hello, good evening, all seniors and colleagues. Let me just share my screen first.
Dr. Kranti will be sharing on non-epinephrine versus dopamine in neonatal septic shock. And our expert for this topic will be Dr. Om Prakash Jamadar, sir.
Madam, is my screen visible?
Yeah, is it visible?
Yes.
Yeah, it is.
Good evening, everyone. Today I'll be presenting this original article of the study of norepinephrine versus dopamine for septic shock in neonates, a randomized controlled trial. This study was published in the Journal of Pediatrics in July 2025. The journal has an impact factor of 6.4. Introduction. Sepsis is one of the most important causes of admissions to NICU and has contributed significantly to neonatal morbidity and mortality. There is still a lack of very well-defined management protocol when it comes to fluid refractory septic shock in neonates. The choice of first-line ionotrope or vasoactive agent is largely till today at the discretion of clinician in the NICU, with dopamine being the most commonly used agent in most of the NICUs across India. The objective of this study, which we are discussing today, was to assess the effect of norepinephrine versus dopamine as first-line vasoactive agent in neonates with fluid refractory septic shock. Coming to the study design, it was a double-blind, parallel group randomized controlled trial conducted at a tertiary care hospital in northern India. Duration of study was 18 months from February 2023 till July 2024. Study sample was 80 neonates, including both term and preterm neonates, who were diagnosed with fluid-resistant septic shock and were admitted in NICUs. The term neonates were enrolled till 28 days of life, and preterm neonates were enrolled until 40 weeks of postmenstrual age. Shock in this study was defined as adapted from the American College of Critical Care Medicine guideline as the presence of hypotension defined by systolic or diastolic or mean BP less than third centile for the gestational age, along with any two of the following criteria: either urine output less than 0.5 ml per kg per hour in the last 12 hours, CRT more than 4 seconds, high serum lactate more than 5, metabolic acidosis with a base excess exceeding 5 millimoles per liter, or reduced superior vena cava flow less than 40 ml per kg per minute. Hypotension in babies was assessed with invasive BP monitoring through an umbilical or a peripheral arc line. Fluid refractoriness was defined by failure of reversal of shock after reception of one or more fluid boluses by the babies. The diagnosis of sepsis was based on either a positive blood culture report, a positive sepsis screen, and in some babies, even with a compatible clinical course in babies who had received at least 5 days of antibiotic. The inclusion criteria in the study was exactly the definition of shock that was adopted, which is mean BP less than third centile with any of the two criteria which we just discussed: low urine output, prolonged CRT, high serum lactate, metabolic acidosis, high base excess, or decreased superior vena cava flow. Exclusion criteria: babies with major congenital anomalies were excluded. Moderate to severe hypoxic ischemic encephalopathy in the first 72 hours of life was excluded. Neonates already on inotropes were excluded. Shock which occurred after 24 hours of any surgical procedure was excluded, and failure to obtain parental consent. 80 neonates with fluid-resistant septic shock were allocated to either receive norepinephrine or dopamine as the first-line vasoactive drug in the study. Norepinephrine was initiated at 0.2 micrograms per kg per minute and escalated to a maximum dose of 0.3 mics per kg per minute. Dopamine was initiated at a dose of 10 mics per kg per minute and escalated to a maximum dose of 15 micrograms per kg per minute. This is the way the study was conducted. So they had taken in total 138 neonates, out of which 14 neonates were excluded as per the exclusion criteria. Out of the 80 babies who were selected for the study, they were randomized into two groups of norepinephrine and allocated to dopamine. 41 babies were allocated to the norepinephrine group and 39 were allocated to the dopamine group. On follow-up, there was no loss to follow-up in both the groups. On analysis, all the babies in both the groups were analyzed. There was no death, no loss to follow-up. Coming to the primary objective of the study. So the primary objective of the study was to study incidence of shock reversal at 30 minutes after initiation of vasopressor support, either norepinephrine or dopamine in the respective groups. Shock reversal was defined as mean BP more than third centile for the gestational age, along with these two clinical endpoints, CRT less than 2 seconds, or normal pulses with no difference in the peripheral and central pulse quality, or warm extremities. The secondary objectives which were studied in this study were changes in the cerebral tissue oxygen saturation levels in babies in the norepinephrine and dopamine group, need for further escalation and need for a third vasoactive drug, time to reversal of shock, requirement of steroids over and above the inotropes, incidence of hyperglycemia, tachyarrhythmia, and sinus tachycardia due to each of these respective drugs, need and duration of respiratory support in the neonates, and changes in the following biochemical parameters: pH, bicarbonate, base excess, and lactate at baseline, at 6 hours, at 24 hours after diagnosis of shock. Coming to the study protocol, all the 80 eligible participants were randomly assigned to receive either norepinephrine or dopamine. I'm so sorry. Yes. So, yes. So all the participants were assigned to receive either norepinephrine or dopamine in a 1:1 ratio, and they were stratified into less than 35 weeks and more than 35 weeks subgroups. All study investigators and healthcare personnel were blinded. Study nurse prepared the infusion in a 50 ml syringe and labeled it as study vasopressor. She handed the syringe over to the bedside nurse. The norepinephrine and dopamine solutions, once loaded in the syringe, looked identical. They had similar rate of initiation, which was 0.4 ml per hour. Blinding was not compromised. The intervention drug was given preferably through the most proximal port of the central line and when not available through a peripheral line. Shock reversal was assessed after 15 minutes and 30 minutes of initiation of vasopressor support. Coming to the statistical analysis, the reversal rate of shock with dopamine in a previous study, which was epinephrine versus dopamine in neonatal septic shock, published in European Journal of Pediatrics in 2018, was reported to be 30%. Assuming this similar proportion of neonates having shock reversal with dopamine and considering norepinephrine to have 30% greater chance of shock reversal compared with dopamine, they considered a sample size of 80 neonates, which was calculated with 80% power and a two-tailed alpha error of 5%. For categorical variables, Fisher exact test or chi-square test was used. For continuous outcomes, Mann-Whitney test or independent t-test was used. P-value of less than 0.05 was considered significant. Here, am I audible?
Yes, yes.
Go ahead.
Continue.
Yes, sir. Yes, sir. So these are just a couple of baseline characteristics which are being compared. When it comes to the gestational age, both the categories in norepinephrine and dopamine, the babies were on an average gestational age of 33 plus 4 weeks. Birth weight was also similar. There was no difference in the two groups. Most of these characteristics, if you see, there is no clinical significance except one, which is the cerebral region saturation, CRSO2, which I have highlighted, where there was a significant decrease in the cerebral region saturation levels in the dopamine group compared to the norepinephrine group, with a significant p-value of 0.09. Rest all of these parameters were comparable and there was no significant difference. Results. The proportion of neonates attaining reversal of shock by 30 minutes of initiation of vasoactive support was similar in both norepinephrine and dopamine groups. Requirement of an additional or a third vasoactive agent and steroids was again similar in both the groups. Incidence of hyperglycemia was again similar in both the groups. Dopamine, though, had a higher incidence of tachycardia compared to norepinephrine group. The incidence of tachycardia was 2.4% in babies with norepinephrine, and it was 15.4% in babies started on dopamine. There was no difference in the all-cause mortality between the two groups. The mortality was comparable, 58.5% in norepinephrine group and 56.4% in the dopamine group. The cerebral region saturation, as we discussed, the values were similar at 30 minutes and 6 hours post-initiation of therapy in both groups, but significantly lower at 24 hours in the dopamine group. Neonates in the dopamine group were significantly also found to be more acidotic at 24 hours after initiation. Coming to the table of primary and secondary outcome variables discussed in this study, reversal of shock at 30 minutes, if we see, of initiation of vasoactive support was again similar in both the groups. 13% babies had reversal of shock in norepinephrine group, 18% babies had reversal of shock at 30 minutes in dopamine group, with p-value not being significant. When it comes to other components like correction of hypertension, normalization of CRT, normalization of pulses, again was very similar in both the norepinephrine and dopamine group. Need for second vasoactive drug, third vasoactive drug, again similar in both the groups. The only significant difference here was in the incidence of tachycardia, where tachycardia was found to be way more in the dopamine group compared to the norepinephrine group, with a significant p-value of 0.05. The rest, all of the findings, including mortality, incidence of NEC, BPD, were similar in both the study groups. This we've discussed, this I've already discussed, that the cerebral region saturation was much, much lower in dopamine group at 24 hours of study. pH also, as we discussed, the babies were more acidotic in the dopamine group compared to the norepinephrine group, with a significant p-value of 0.04. The pH in dopamine group was on an average 7.13, whereas in the norepinephrine group it was around 7.27. This is a coincidental finding or a concomitant finding that was observed, that of all the septic babies who were enrolled in this study, 59% turned out to have culture positive Klebsiella, 20% had Acinetobacter, 8% were E. coli, 5% had Pseudomonas aeruginosa, 5% had MR cons, and 3% had MRSA as the sepsis causing organism. Coming to the discussion, there is still a lack of well-defined management protocol when it comes to fluid refractory septic shock. Plausible reasons include unclear definition of hypotension in neonates and a lack of robust evidence. Most of the current practices in neonates are presently extrapolated from the adult and the pediatric guidelines. Dopamine still continues to be the most common first-line agent in neonatal shock, despite lack of strong evidence. In contrast, norepinephrine is very infrequently used in NICU, although it is the recommended first-line agent in adults and children with septic shock. Recently published pediatric and adults survival sepsis guidelines prefers the use of norepinephrine over dopamine as the first-line agent for management of septic shock. There are several pharmacological factors which support the use of norepinephrine and make it superior over dopamine. First being the pathophysiology of septic shock, which involves a low systemic vascular resistance, which can be addressed adequately by a potent alpha-1 agonist like norepinephrine, which increases the SVR. Dopamine exerts its action through the release of norepinephrine from the nerve endings, and this might become a limiting factor in sick neonates who already have limited reserves of norepinephrine. The metabolism and clearance of dopamine is dependent upon postmenstrual age and may cause drug accumulation in unstable preterm neonates. Norepinephrine also reduces pulmonary vascular resistance and improves pulmonary hypertension, which is a common association with neonatal sepsis in babies. So what does this study conclude? This study concludes that in neonates with septic shock, norepinephrine and dopamine in this study had comparable efficacy as the first-line vasoactive drug. Although not statistically significant, but dopamine had a higher rate of shock reversal at 30 minutes which was more pronounced among preterm units less than 35 weeks. No major adverse effects were noted with norepinephrine effusion in the neonates. Norepinephrine had a potentially better safety profile compared with dopamine. Incidence of shock reversal and mortality was 40 and 60%. In our study, the one that we are discussing, we did not observe any mortality benefit with norepinephrine. But in the other studies, such as the study that I've written here, published in European Journal of Pediatrics in 2023, which was a retrospective study of comparing dopamine and norepinephrine for sepsis-related hypotension only in preterm neonates. In this trial, norepinephrine was found to be associated with lower mortality. But in our study, we did not find any mortality benefit with norepinephrine. Dopamine group, on the other hand, had significantly lower cerebral region saturations, more acidosis at 24 hours, higher base deficit and PCO2 levels, indicating that there is a possible adverse effect on tissue perfusion by dopamine. Now, as we concluded in our study, we saw a better rise in mean BP at 30 minutes with dopamine compared to norepinephrine. A similar trend of higher rise in mean BP at 30 minutes was also observed by a different study called as Hypotension in Preterm Infants Randomized Controlled Trial, which was published in February 2021. In this study, they had compared two groups, one group which had received saline boluses followed by dopamine, and the other group which had received saline boluses followed by placebo. So in this group also at 30 minutes, they found that the shock reversal was better with dopamine. But I felt that this study is a little flawed because they are comparing dopamine with a placebo. So this would anyway show that 30 minutes, the shock reversal would be better with the inotrope. Limitations of our study: modest sample size, not sufficiently powered to detect clinically important differences in the primary outcome and neonatal morbidities. The neonates who were included with shock, the neonates included had shock, were hypotensive at recruitment. Intubated and non-intubated infants were not specified and not subgrouped in any of the data that they have published. Lack of differentiation between cold and warm shock. There was lack of echocardiographic assessment of the cardiac function to guide choice of vasoactive drug, like IVC collapsibility, they have not mentioned. They did not evaluate the outcome of neonates beyond discharge, and they did not evaluate the long-term neonatal development or neurodevelopment in the neonates following discharge. Conclusion of this study is that norepinephrine and dopamine have comparable efficacy in neonates with fluid-resistant septic shock, but dopamine had higher incidence of tachycardia, more acidosis, lower cerebral region saturation at 24 hours following initiation of therapy, indicating that norepinephrine has a better safety profile compared to dopamine. That ends my presentation.
Thank you, Dr. Kranti. Your presentation was very elaborative and wonderful. I request our expert of today, Dr. Om Prakash Jamadar sir, to give his expertise comment. Over to you, sir.
It's a very important topic. In fact, I will say we use so much of inotropes in neonatal sepsis. So as far as this study is concerned, the study population, one is the numbers are quite less. Then second, we can't mix term babies and preterm babies because in this, the responsiveness for both these population is totally different. I will say preterm need to be segregated and term need to be segregated. And plus, the onset of shock is also very important, whether the onset is within, I will say within 72 hours or after 72 hours. Like a late onset sepsis will behave differently and early onset sepsis will again behave separately. Here they have taken less than 35 weeks and more than 35 weeks and 28 days for a term baby and 40 up to 40 days for 40 weeks of corrected gestation for a term baby. So there are few challenges in terms of interpretation because of this. Another thing which is very important for us classes is the bedside responsiveness. So if you look at the early markers, they did look at the CRT. The heart rate is another parameter which may be an early markers to find out whether there is early stage of shock. If you compare the baseline heart rate and if there is changing trend of heart rate, that is another limitation, I will say. And interestingly, other studies, if you compare, norepinephrine is preferred in comparison to the dopamine, but in this study, it is showing equivalent response. So these are few, observations by me. And 2D Eco, as they said, we need to assess 2D Eco. In-house 2D Ecos are most of the places they are available. We need to understand the fluid status as well as the SVC filling is also going to be an important markers to give whether there is subsequent boluses. We should not go at the same time, more than 2 boluses should not be given. But there are certain limitations as I discussed in these studies.
I also invite Dr. Tanmesh Sahu sir to give his opinion.
Hello. So it was rightly said by Dr. Om Prakash sir. Basically, what they've done is basically a subgroup analysis. In fact, they've segregated, they stratified the data to less than 35 weeks, more than 35 weeks. But I think when we stratify the data for less than 35 weeks, the power gets reduced of the whole study. The post-hoc analytic power comes reduced. And secondly, when you start inotropes in a baby, that has to be very much individualized. And without a perfectly, as said, 2D eco functional echocardiography, you cannot decide, you cannot just make a protocol that for any septic shock start with noradrenaline or norepinephrine first. You have to identify the basic parameters always. And moreover, in the base, I think in the baseline characteristic, that cerebral oxygen saturation was actually not significant. It was the p-value was 0.09. And in the whole article, I think sample size was a little bit lesser. They could have taken. And if we, I'd actually gone through this article, if we calculate the power, they have assumed that the norepinephrine is 30% more than what the dopamine is doing. So when we calculate and put it in the statistics, the sample size coming is little bit higher. So have they taken 30% of 30% or 30 plus 30, 60% they've assumed. So that is one thing that is not correlating with the sample size, what I've gone through. Rest all, it needs a larger mode trial. We cannot give a consensus decision that for any warm shock or any septic shock, start with norepinephrine first. So it will be always individualized and has to be go through bedside 2D functional cardiography as well.
Thank you, sir. Rest of the queries we will take at the end of both the presentations. Now I request Dr. Rajat to share his presentation.
Yes, ma'am. Good evening. Good evening, everyone.
Please share your presentation.
Yes. Good evening, everyone. I'll be. My name is Dr. Rajat Nagargoje. I've completed my MD Pediatrics in here in MGM Hospital back in February, and I'm currently working as senior resident in MGM Hospital Kamote. Thank you for the opportunity. I'll be presenting a journal club discussion. The topic that we are going to that I'm going to present was the article was published in the Journal of Pediatric Clinics of North America. It was published in August 25 and April 25 and issued in August 25. The topic of the article was recent advancement and best practices for supporting newborn feeding. It is a narrative review, and the impact factor of the journal is 2.4. So introduction, as we all know, exclusive breastfeeding is crucial for infant and maternal health, as recommended by both American Association of Pediatrics and World Health Organization, that exclusive breastfeeding should be done up till 6 months of age. This review clearly outlines updated evidences and practical recommendations for us as clinicians. So the global recommendations state that we need to practice the WHO 10 steps of successful breastfeeding and to promote exclusive breastfeeding up till 6 months, and it needs to be continued up till 2 years of age. Sorry. And the newborn need not be given any pre-lactal feeds unless very rarely medically indicated. And also the recommendation is to support skin-to-skin contact and rooming of the mother and baby diet. When it comes to health benefits of breastfeeding in infants, it reduces neonatal and infant mortality, and also reduces the risk of sudden infant death syndrome. It prevents otitis media, pneumonia, and diarrhea, and it is a proven it is a proven fact. It reduces allergies, asthma, obesity, diabetes, and inflammatory bowel disease and leukemia. When it comes to benefits for mothers, it reduces risk of breast, ovarian, endometrial, and thyroid cancers. It decreases the risk of type 2 diabetes and cardiovascular disease as well. It promotes postpartum recovery and maternal and infant bonding. The contraindications that were there given by the article by the author, the absolute contraindications for breastfeeding were a classical case of galactosemia, case of classical galactosemia. Along with that, human T lymphocytic virus 1 and 2 infection, untreated brucellosis, and Ebola infection. While the relative contraindications being active lesions on nipples, such as a mother having bleeding nipple and she herself suffering from hepatitis C, and also the emerging monkeypox. When it comes to HIV, according to the narrative, the peer review, they have mentioned it that if it's if breastfeeding is possible if the mother is on antiretroviral therapy and if the viral load is less than 50 copies per ml. This that the author that they have reviewed is something different that we practice in our according to our NACO guidelines. In our guidelines, we usually classify the mothers based on the high risk and low risk for HIV transmission. And decision on breastfeeding is taken accordingly, and to start either a single drug therapy or double drug therapy, and the duration of the therapy. When it comes to skin contact, as the guidelines mention, the golden hour is critical for the physiological stability. The skin to skin contact vitally stabilizes the neonate. It stabilizes the heart rate, respiratory rate, prevents hypoglycemia and hypothermia as well. And it enhances breastfeeding initiation, the duration, and exclusivity. It benefits both the modes of delivery as well, the vaginal and cesarean section. I've also mentioned about the Windstorm 9 stages of breast cord that needs to be practiced on a regular basis to facilitate the skin to skin contact and facilitate the breastfeeding initiation. When it comes to paternal involvement, the father's skin-to-skin contact improves neonatal adaptation and parental bonding. It reduces the father's anxiety and enhances his confidence. It also promotes family-centered newborn care. As we know, the rooting reflex usually appears at 28 weeks of gestation, and the suck-swallow breathe coordination, it matures after 34 weeks. The skin-to-skin contact stimulates both the reflexes and enables infant-led latch. Now coming to what the peer review says, that the HIV transmission, if it's less than in a mother suffering from HIV, if the mother has less than 1% of virus suppression, then only the transmission risk reduces. So the breastfeeding can be given if the mother is on ART and has viral suppression. But when it comes to hepatitis B, breastfeeding is completely safe, and the lactoferrin indeed reduces infectivity. And the combination of hepatitis B immunoglobulin and hepatitis B vaccine gives a safer mode of the feeding to the child. When it comes to hepatitis C, it is safe to breastfeed unless there's a cracked nipple or active bleeding. And the COVID-19 and influenza, if the mother is having, breastfeeding can be continued provided proper precautions are taken. And they can also do rooming in together. When it comes to our guidelines, for a mother suffering from for breastfeeding mother suffering from HIV, so what we follow is NACO guidelines, and the replacement feed choice we are guided by this AFAS criteria. If the criteria is met, then only the replacement feeding can be given. Otherwise, if it's not met, then exclusive breastfeeding is recommended. When it comes to breastfeeding during infectious outbreaks, they have also, the peer review has also covered about the emerging monkeypox, and they have specified that to avoid direct breastfeeding until the active lesions are healed. To maintain lactation, they may pump and discard the milk. And for safety reasons, the newborn has to be separated temporarily from the mother until the lesions subside. For the medication safety during lactation, although most of the drugs are quite safe during lactation, there are resources that we as pediatricians can use that include Lactmed, E-Lactantia, infant risk centers, and Hales medication and mother's milk. So these are resources that we can use to see if the drug is safe or not to be used during breastfeeding. Now, coming to monitoring of weight loss in newborns, normally up to the normal term newborn can lose up till 7 to 10% in the first 7 days. And if it's less, if the weight loss is more than 10%, it is usually accompanied with neonatal hyperbilirubinemia and hypernatremic dehydration. So they need to be evaluated. So according to the peer review, the use of this tool, the newborn weight loss tool, it has to be done to identify abnormal weight loss trends. The tool used percentiles of weight loss that were evaluated on discharge on day of life 4, and they had used about 100,000 babies for calculating the percentiles. And depending on the type of delivery, if the percentile loss was more than 90% in a normal delivery and more than 75% percentile if in a cesarean section, it was considered abnormal. Coming to vitamin D and micronutrient supplementation, it is recommended that 400 international units of daily vitamin D is to be given for all breastfeed and formula fed infants, and to supplement the baby as well if the mother is having a vegan diet or limited sun exposure. And the review also states gives a discussion about Medi-Aid families. It is a form of insurance for the people living in USA, and if they are not able to afford the vitamin D supplementation, they can get the vitamin D supplementation at a lower price through this insurance claim. But the newer guidelines, the ISFAGAN guidelines, they have said that if a term baby, they now need 400 to 600 international units per kg per day of vitamin D, and maximum we can give is 1,000 international units per day. Now, social determinants of health for breastfeeding. The economic instability, housing insecurity, and transportation issues, they affect the breastfeeding of the baby. The low income and minority families, they face breastfeeding barriers. Hospital discharge planning should include such social determinants of health screening tools. What we can do is like what they are using in USA is the housing instability vital sign and hunger vital sign, so that on discharge these the families are identified as high risk families who will be most probably after discharge will be discontinuing breastfeeding due to any of the social determinants of health issues. And coming to equity and bias in breastfeeding support, the author that they have given as the Black mothers that they reside in America, they often receive less lactation support, and unconsciously the bias that it affects feeding recommendations as well. So culturally competent counseling is needed, and it improves the outcomes. Coming to substance use in breastfeeding in America, it is said that at least 5% of the mothers who have given birth, they are involved in illicit substance use. So the Academy of Breastfeeding Medicine 2023 protocol, it says breastfeeding is possible in these mothers provided there's abstinence of use of illicit substance at delivery. And also these mothers they should be avoided of any form of discrimination, and they need proper multidisciplinary care so that they don't relapse. And when it comes to special situations where feeding of late preterm and multiple infants, they often need supplementations, replacement feeds. And when it comes to twins and multiples, feeding needs to be promoted, and each individual is assessed individually, so to determine if breastfeeding is adequate or not. And milk expression is encouraged if latching difficulties are present. Lactation support systems are according to the peer review, they have said that the hospitals should follow the baby friendly hospital initiatives, and when they follow that, they have higher initiation exclusivity rates of breastfeeding, and post discharge lactation support can be given, and by like the pediatricians, especially the pediatricians practicing breastfeeding medicine, proper lactation consultants and peer counselors, and there are multiple organizations such as Women, Infant and Child Program. It is a government organization, and Lalish League, a non-profit organization. They provide lactation consultation and tele-lactation via video and messaging. It also effectively can be used for giving breastfeeding support. And coming to this topic of breast milk and the microbiome, human milk has shown to promote beneficial gut bacteria such as bifidobacteria, lactobacilli, and direct feeding enhances the maternal and infant microbial exchange, while the exclusive pumping alters the infant gut flora diversity. When it comes to long-term impact of the microbiome, early microbial colonization that can be done by direct breastfeeding can affect the immune system and metabolic health, and it may reduce the risk of obesity, allergy, and autoimmune disease risk. And research is currently ongoing on prebiotic and probiotic interventions as well. Discussions. The skin-to-skin contact and equitable lactation access, it improves the breastfeeding chances, success rates, and early identification of feeding issues using the newborn weight loss tool and clinical observation does help. The addressing of maternal nutrition and psychological support also needs to improve. And as pediatrician, we need to advocate for hospital policies that support skin-to-skin contact and grooming in, and also to educate the families on vitamin supplementation and safe medication use. We should also adopt baby-friendly breastfeeding health initiatives and support human milk donor access. And the staff and the parental counseling should be done, and staff needs to be continuously educated on it. When coming to the strengths of the peer review, I found the study to be having comprehensively covering both the evidence-based feeding support as well as lactation counseling, and interdisciplinary approach has been seen, which includes pediatrics as well as the lactation experts. And the review also integrates WHO and American Association of Pediatric recommendations, and it also highlights the clinical tools such as those for safe drug use and the for newborn weight loss tools, and equitable care approaches are also covered. When it comes to limitations of the study, I found the study to be having narrative nature, the narrative review, and it had some form of bias, the author bias that is there. While the study was done in America, so mostly data is from that country as well. More data has to be needed from low income studies, and the implementation of the social determinants of health strategies needs a proper local adaptation for it to affect the breastfeeding results. And in conclusion, I want to say that breastfeeding still remains cornerstone of neonatal nutrition, and the social determinants of health screening, lactation support, and maternal health optimization is crucial. And for future focus, microbiome research, tele-lactation, and integration and equitable policy implementation is to be done. That's it. Thank you.
Dr. Rajat, you can stop sharing.
Yes.
And I would request Dr. Sahu sir to please give his expertise comment, sir.
So it was a very nice presentation, Rajat. So the topic was recent advances and in breastfeeding and the new practices. So rather everything we know about it. So the topic should have been like reinforcement of what we know. So before going into this, I would like to put up a statistics of National Family Health Statistics Phase 5, where the breastfeeding within first hour was 41.8% in India, and exclusive breastfeeding for the 6 months is 63.7. So these very dismal numbers. So you can say I have also seen the number of cesarean sections in the, in government sector, it was around 27%, and number of cesarean section in private sector is something around 47% as per NFHS 5 data. So this should combine everything of all of the topic today. That exclusive breastfeeding and breastfeeding within first hour is being totally means somehow it has been written in the books and being practiced very less. So we can say sometimes like you can see the like delayed cord clamping of the recent guidelines saying up to 60 seconds. How many of us and how many gynacs allow you to do that? So this is something we need to discuss with this, and we need to increase that, and skin to skin contact, as he read about it, that various benefits of the skin to skin contact and the 9 stages of breast cock, that is Windstrom's 9 stages, that only we can find in the picture in the Google. So to find it that particularly and practice in all child and all babies, so this will be very important for us. So now second thing, what is more in research is coming to be the microbiome. Yes, there's a lot of talk in this. So coming at the increasing numbers of cesarean sections and decreasing number of the normal deliveries. So I would say rather that the whole microbiome is getting changed. Babies at 1 year, 2 years getting more of early wheezers. They're getting dermatitis. Most cases, we're not seeing it like 10, 15 years back. Such cases, I don't think that much there. But now with this change in microbiome and everything, it changes because the useful bacteria, that bifidobacterium, lactobacillus, everything has changed from a normal delivery, and when it goes to a cesarean section, the whole microbiome changes. So they have found a recent concept in ACOG. They have published this data in 2023, something called as vaginal seeding. What they did it in cesarean section mothers. They used to keep a vaginal swab at least 1 hour before the section, and after the delivery, and the baby is stabilized for first 2 minutes. They used to swab that vaginal swab in baby's mouth, face, and skin, so that the baby gets all the microflora. But this is all under controversy right now. ACOG is not recommending that because it would also transfer some of the pathogenic bacteria. So look at the concern, what they're trying to do. They're trying to change the microbiome because this gut-lung axis, gut-brain axis, everything gets stimulated by this thing. And the whole of your morbidities like dermatitis and all metabolic syndromes is what your microbiome is changing. Because we are, as an individual trait, we are because of a symbiotic relationship between our gene and the microbiome. So everything is getting changed. Now, something which for an good feeding practices, I would say the best line is early aggressive enteral nutrition is the norm. It should be norm for all babies. Especially, we should be cautious for babies less than 1 kilo. But for VLBW babies, if the baby is stable, you should start early aggressive enteral feeding from day 1. There was a trial where I done that. I was a PI of that study. So we had tried complete feeding from day 1 of VLBW SGA babies. Even those babies were severe SGA, less than 3rd centile as per Fenton's chart. Even those babies reached that early feeding, to reach that full feeding very early. They were discharged from the hospital very early, and neurodevelopmentally also they're very much fine. So even now there are studies going on that in babies whose mother had this abnormal that reversal of diastolic flow, absent diastolic flow, even they are getting started feeds very early. So early aggressive enteral nutrition is the first thing. Second thing, we forget about colostrum coating in ELBW babies. That is otherwise called as a oral immune therapy. So even if the mother has a drop of milk, that drop, if it comes at around 0.2 ml, you can directly put it in a syringe and swab the whole buccopharyngeal mucosa every 4 hourly for at least 2 days. It will help to maintain that microbiome. And they're also suggesting that even if the collection is 0.1 ml, you have to dilute 0.1 ml of sterile water in that and give it again through a syringe to the buccopharyngeal mucosa. And second, as per the MA program, Mother's Absolute Affection program, what they've been training the ASA workers and everything for the increased breastfeeding tendencies. So they have planned for lactation management units to be present in every center, at least. CLMC should be present in the tertiary centers, and lactation management unit should be there, because many things happens is that the delay in feeding, this is the main cause why we have so dismal rates in the exclusive breastfeeding breastfeeding within first hour of life. Then something he discussed about, that is the feeding in HIV positive mothers. It depends on the titers they do at 32 to 36 weeks, and the FAS criteria only if they're affordable. They can, and now there is a concept that earlier it was a concept that mixed feeding to be avoided, but now at least they have made it that even if the mother doesn't have a complete milk output, mixed feeding is allowed. At least milk has some benefit, or at least from the one that if without giving milk, so it has got good benefits. And about KFC. something. Why should mothers have all the fun? So in our units, we used to give kangaroo father care. So they feel very happy about it. Mothers don't get tired. The child gets adequate kangaroo father, kangaroo care, everything. So that is one thing. And one more thing that is in recent advances is that drugs. So many mothers, they get confused ki I'm on such type of drugs, I'm on on antibiotics, on even the fear to give breastfeed, even they're on cetirizine. So these are good apps like that Hale's Medicine Encyclopedia and that Lactaid. So this all defines about something called as a in that book. If you put a particular drug, say for example lamotrigine, mother is in some kind of epileptic seizure on lamotrigine. So you will find when you put that drug in that article book, they will give you some data like a milk plasma ratio or something called as a RID, that is relative infant dose. So generally it is said that what is relative infant dose? That is basically the dose that the baby gets divided by the mother's weight. It is adjusted on both the weight. So if that percentage is less than 10%, then it is absolutely safe to be given. And if it is more than 25%, then you have to look for it. So this data will get in that particular apps and this thing. And regarding that new tool, what they have mentioned, that is newborn weight loss tool. Basically, I would say might have created that centiles basing on the babies in North America. So we might have to create such tool in our own country for our own babies so that we can follow up that. But blindly, we can say that 10% weight loss, we don't have to wait for 7 days to find out the 10% weight loss. For each day, if the weight loss is more than 2.5 to 3%, then you should be worried about the feeding. And regarding late preterm feeding, we need lactation aids, definitely. And I think this has everything we know. We just have to reinforce what we know. Thank you.
Thank you so much, sir. I request Jamadar sir to give his opinion, sir.
I think it's a very important takeaway for everyone that we used to be proud of breastfeeding, but nowadays we are not so much. I hope I'm audible.
Yes, sir. Yes, sir.
So breastfeeding has gone down quite significantly in Indian scenario. And I must say the contributing factor is we also are equally responsible for this problem because we don't initiate initial skin to skin contact, and the first golden hour feeding that has to be initiated by all of us. We need to convince the obstetricians. That is the major challenge in many of the situation. As we are moving for a delayed cord clamping, I think we need to look forward to early initiation of the feeding, not only in the term babies, but also in the preterm babies as reinforced by him. Otherwise, I think there are some things that we need to keep in mind in like in a seropositive status. Another thing which is coming, we need to be aware of something called as the neonatal abstinence syndrome, because we are seeing the high profile parents like they are having a different conditions nowadays. So we need to be aware of neonatal abstinence score where the mother is exposed to certain drugs and then child is having symptoms of that. So that also we need to keep in mind considering the advances in other social economic issues that we are facing nowadays.
Yes, sir. Sir, can you highlight about oromotor stimulation techniques and also PYOMI? This is also a new recent advancement we have seen.
So as far as oromotor stimulation is concerned, like particularly babies who have got difficulties, like late preterm babies or babies having perinatal asphyxias, these are the babies who have got difficulties for initial latching and sucking. So we do involve our the early intervention. What we say we have got certain brushes, like you must have seen the electric brushes. So we do use that sort of things in small babies to give them the stimulation. And then as we know, the touching at the angle of the mouth and the 5 points that we look at. So that is another technique. And then good to start once, particularly for the preterm babies, as I said, once babies turning around 1.2 kg, gestational age of around 30 to 33 weeks, we need to start early initiation of the non-nutritive sucking. That itself is the best oromotor stimulator. That is what I will say.
Yes, sir. Mohite sir, do you want to ask something?
Yeah, Mohite sir.
Yeah, I think they have given extensive. Dr. Tanmesh Sahu has given such an extensive review of the whole thing. Wonderful. And the first session, Dr. Om Prakash gave it. Just maybe a couple of things. I start from the second case that is about a feeding. One part which is probably missed out on this is the antenatal preparation of the breast. The antenatal examination of the breast, and especially their large nipples, retractile nipples, and they are the culprits on the breast milk failure immediately after birth. Because if you start correcting them after delivery with pulling or putting the pressures and all those things, it takes about 2 to 3 weeks. This mother is having engorged breast, lot of milk, but the poor child cannot suck. and putting the breast shield and all really doesn't really make a sense. And by the time the child taking suck or nipple starts coming down, she has lost the milk flow. And that's one of the commonest thing I've seen as the cause of breast milk failure. That's one thing. Second, Dr. Tanvesh Sahu gave wonderful statistics that 41% in the first week and ultimately 63% by 6 months excluding. But believe me, this is a reasonably good number in a continent because China really draws back. In spite of such an education level, still it's around 40-45%. We are not doing very bad, but I'm sure we need to still improve. The Western world is still lagging behind quite a lot on that. So I think we are doing reasonably well on that. That's about the breastfeeds. And about the inotropism, perhaps most of the things are taken from adult followed by pediatric and coming into neonate. First of all, the fluid refractory shock terminology challenge. There is nothing like fluid refractory nowadays. Gone are the days when initially we used to push a lot of fluids 10, 10, 10. And once we see a good liver sagging down, then you start giving inotrop. Today in a septic shock, we never give more than 1 or 2 boluses. So that terminology of fluid refractoriness, I think, need to be changed totally. The surviving sepsis guidelines 2020 and followed by revision in 2022. Beyond 1 or 2 fluids. In fact, now if you ask me in a pediatric, you are a neonates. By the time we pick up a neonatal septic shock, I hardly recall any baby who is recovered just with 10 ml kg of normal saline. So invariably we'll end up with, I would say, almost 90-95. I'm sure both of our faculty will agree that if there is a confirmed septic shock, somebody recovering with only 10 ml per kg with normal saline is almost not seen. I'm very dogmatic on that statement. So almost, so there is nothing like fluid refractory shock. Every shock, you are going to add inotrop. A septic shock, once you confirm, especially hypotensive shock, one single bolus recovering that child is almost never seen. So we'll be having very low kind of a threshold for pushing the inotrop. That's one thing. Second, I was very surprised. This study of only 80 cases with 40 in each limb being published in journal like Pediatrics 6.4. So you can always say that's itself a bias in the present kind of commercially driven things. I mean, Omkar and Tanvesh, don't you agree with me that
Yeah,
only
yeah, the
80
numbers are
cases
quite
with
low.
40 on each line
Quite low.
in such a common condition,
Yes.
in such a common condition of septic shock, he said only 40 being published in a pediatrics. I mean, that's only because it's from US. Had it been, I mean, you take a Cyan or MGM or take this, bloody every month they must be having 80 cases of septic shock. And in the year, there will be at least few thousand cases. So I mean, that's ridiculous. Based on that, you draw some conclusions. Secondly, when they draw almost 60% of Klebsiella pneumonia and 20 of Acinetobacter, I believe this is a late neonatal sepsis. Very likely developed advanced word coming in early and group B, streptococci and all those things. Klebsiella and Acinetobacter, almost 80% of the chunk, almost draws me to the conclusion this is a hospital acquired than the primary. And there I'm sure the protocols are slightly different. They are definitely far more difficult to control. And there again, going back, one more thing I want to ask all the people in the group. How many of you still use dopamine as inotrop in a neonatal septic shock as the first line? I mean, Dr. Sahu and Omkar,
Yes.
you can respond to that. Do we really?
Yes.
You still use dopamine in the first line?
Not much, sir.
No.
I most of the times nowadays I go for Norep. Yes.
Epinephrine. I mean,
Yes.
we go for epinephrine still, and then
Yes.
after maybe one fluid bolus followed by epinephrine into 0.1, 0.2, and then has more than 5 years. What is your take, Dr. Sahu?
Yeah, we don't use actually dopamine, as in we just use
Absolutely.
not in septic shock, at least in those with PDA with shock, we can have a slight thought that shall we use dopamine in a transitional shock. I mean, but epinephrine or norepinephrine would be the first choice.
Yeah. I mean, a rare case where you cannot get a central line at all, and then you have to rely only on the peripheral line, maybe dopamine or sometimes adre. But norepinephrine, I don't use directly. But epinephrine is something which is then a pediatric, and there are a good number of articles. Dopa versus epinephrine versus norepinephrine. Still, the standard of care is epinephrine upfront. And adults have already moved into norepinephrine universally. They are not using other drugs at all because septic shock is predominantly or rather almost exclusively vasodilatory shock. where by physiology also norepinephrine scores above all the drugs. So a lot of limitation to study. Few technical points which I want to suggest Dr. Jain who presented. She mentioned that base excess. She mentioned about a base excess. Actually, it should be base deficit. It's not a
Deficit.
base excess that you see in the definition part of septic shock. She mentioned base excess. So that's not. Secondly, the number which she quoted, cerebral perfusion, and it is significant with a p-value of 0.09. This is from the study
Then
one.
that was not
0.09 is not a significant value. 0.05 and below that is a significant value. Once you 0.09, it's beyond 2 standards, within 2 standard deviation. So it's not to be taken as significant. Just few of the observations have been made. And that's all. Thank you very much. I hope both of them do agree to that. 0.09 is actually not a statistically significant value.
Sir,
Anything
mark
less than,
that.
yeah, it's less than 0.05. She mentioned
Mhm.
0.09, and I think the studies also quoted same. So that's not a clinically significant or statistically significant value. That's what is my submission.
yeah.
Thank you.
Right, sir.
Thank you.
Yeah, thank you. May I request Minash Sheikh sir to give his inputs? Dr. Minash? Dr. Minash Sheikh sir, are you there? Okay, Neha, any question answers from chat box?
No, ma'am, I cannot see any question answers. So we can go for, if there are no queries, we can go for the vote of thanks. So over to you, ma'am, Chitra ma'am.
Yeah. Thank you very much. It was a very interesting session along with the experts and the comments by our mentor, Dr. Nimen Mohanty sir, who has wisely chosen these topics for neonatology, and newly elected Dr. Mahesh Mohite sir and his inputs. It is a ever increasing academic excellence in our journal journey. Along with this, may I give my sincere thanks to Minash Sheikh sir, Dr. Amol Pawar, Dr. Vikas More, Dr. Neha Singh, and Dr. Sanjay Pakmode in absentia because of his family emergency. He could not join today, but he has sent his sincere appreciation also. Also, along with this, I want to thank Pallavi Dharmadikari for her support for the Zoom. Thank you very much.
I can say, see Minash Sheikh sir.
Yeah, I could see Minash Sheikh sir. Minash Sheikh sir, your comments for the today's articles?
I think, in short, both the presenter have present very professionally, very well prepared, very well expressed. So also our both the experts. A lot of learning point. In nutshell, the summary was well given by Mohite sir, wherein we all of us agree that we don't give, even we don't go up to 30 ml per kg, 10, 10, 10. So maximum 30 ml per kg in the older children and the vasopressor in. Similarly, I do agree with regard to Mohite sir and the fluid in the newborn. In fact, most of us will agree we give 5 ml per kg rather than 10 ml per kg in newborn also. We give 5 ml per kg and we bring the early vasopressors. In our unit, generally speaking, sir, we are using the cardiac cases epinephrine and non-cardiac cases norepinephrine. This has been the practice with us. And of course, all of us will agree the practice change is very difficult. Like, in our units, we have some people who are old timers, some people are young and some are middle age. So old timers still do not want to go change to dopamine. And it's always been a tussle. I mean, I'm very honest about this and most of us will agree. So that's one thing, but the practice, the change is always difficult. Transition is always challenging, but still we are doing better and better. And we see in our presentation. So thanks to all of us. This is from my end. Thanks a lot.
Thank you, sir. And I could see Dr. Nimen Mohanty sir has joined from a train. Sir, your comments, please. Mohanty sir.
I think enough we have discussed. We have conducted some small studies, whatever we have discussed today. In MGM, we have seen that the breast crawl is very useful. And we have conducted in breast crawl in term and preterm babies also. I have seen that the initial so-called loss of weight of 10% doesn't happen with the breast-growth babies as compared to the normally conventionally managed babies. We do not know the cause. Maybe, and secondly, the breast-growth babies grow in a different footing. See, their DDST is different. Their weight growth pattern is different. The brain, particularly the head circumference, is different as compared to the other control babies. So we have to still work on it. What is the responsible for that? And rather, we have to go in their gynecologist friends. With their cooperation, this will not happen. This is their domain. They say they will hand over the baby to the pediatrician and forget the baby. The breast call, they don't give time. Similar, the delayed clamping of the cord, this is also they don't cooperate. And the counseling of the mothers in antenatal period, unless they cooperate, it will not happen. I have done some work on this in PGI Chandigarh. Nobody talks about this breastfeeding and issues. Preparing a mother about breastfeeding in the antenatal period is very, very important. We have to take Foxy into our fold, and maybe we have to take our gynecologist friends. Thank you.
Thank you so much, sir, for your comments. And I think any questions from the YouTube, Pallavi ma'am? I think she's not responding. No.
Next month.
No,
next
ma'am.
month
No
topic.
questions.
Yeah,
No questions, ma'am.
Okay.
Yes, Monte sir, you are
Sir,
telling next month's.
Yeah,
Next
sir,
month's
your declaration for the next month topics.
Yes,
Yes,
you can say that. We have already chosen topics. You can announce that.
Yes, sir. I will announce in the group. Thank you so much. Good night.
Good night.
So thank you for to all the attendees on YouTube as well as Zoom, and we will be back on next December 1st of December with two new topics. Over now, we
Thank
can
you.
stop.